In the name of Allah, our dear guests, all of those who are following us from all around the world, welcome to all of you again in the third session of this conference of the researchers and experts of Yemen. This is a third session under the title of the health. Hope it's not because we are not a people that we do not want to find the solutions. So let us discuss together this title, Health Our Way Out. Let us discuss the situation of the health system in Yemen and how we can rebuild it and develop it. As you saw in the previous session, the infrastructure of the health facilities in Yemen is facing many problems, and there are many problems where are affecting the health sector. So these recommendations will form a roadmap to rehabilitate the health sector. As you noticed in the previous sessions, we have many problems like the lack of the efficient staff members. And here we'll be talking about several issues to increase the staff members and to give more attention to the health education and merge between the health treatment and the general health problems, and even using AI to help the patients in Yemen. With this session, we have 5 researchers and experts from Yemen on the stage. I have 3 of them, and they are Dr. Abdul Qadir Bayazid from Hadramaut University, and Dr. Hamdi Al-Hakimi and Dr. Khalid Al-Siraimi also are with us. And online we have Dr. Manuel Baburek, and consultant from Ukraine, and Professor Mustafa Al-Absi, and he is the Chair Professor of Neuroscience and Behavioral Medicine and Director of the Institute of the International Health Research University of Minnesota. Let me start with Dr. Mariam Burek. She is a consultant in global and international health in UK. She had her MA from Leeds University in UK, and she's working in a NAFID Center for International University and an active member in public health. And she worked as a health project manager in a number of international and national organizations like the World Bank, UNICEF, and others. And she worked, before she left to UK, as a staff member in Science and Technology University in Yemen. And she has 25 years of experience, practical experience in scientific research, and she acquired many rewards and many other things. Dr. Mariam, do you hear us? You have the mic. Can you hear me? Yes. Thank you so much for this introduction. Actually, I was shocked to hear all of this. So thank you so much for hosting me. And I hope that we will learn from each other in this conference, and it will be a way to make the Yemen happy and to build Yemen. Actually, my presentation is in English. However, I will try to combine English with Arabic because I started to forget some of my Arabic. As you presented, we want to talk about solutions, and in order to talk about solutions, let us remind ourselves with the main problems that we have and that we can solve. Everyone knows that Yemen is suffering from many problems because of the humanitarian crisis, and it is one of the worst crises in the world, and because they are suffering from insecurities and from a destruction from health facilities, migration of specialized staff members who, in its last report, said that only 50% of health facilities is working with full capacity in Yemen. And this is not only because we do not have doctors or because of the lack of the numbers of staff, etc., but it's also because for more simple problems like lack of electricity, lack of pure water, lack of medicines. And this is a problem that it's not only solved by rebuilding the health sector, but we need to rebuild other sectors. The idea I want to talk about, after reviewing the literatures, the national and international literature about the situation of Yemen, I tried to define the pathway to establish this system and make it more stable, to have a quick recovery. So that way I will share with you the most important things I found out when I reviewed the literature, especially in the things related to the international NGOs, the donors, the interventions, and the donor recourse, all of these on the ground. And there are a lot of reports that was not published and no one was able to reach, but I tried to exert effort to do it. So first, the first thing, or the first places that from my database was from the World Health Organization through UNICEF, UCHA, and Doctors Without Borders, who again, besides the research published in peer-reviewed journals. So today the crisis happened way long time ago, since 2014, which increased the fertility rates. If we took only one of these indicators in the UN report issued in 2022, it says that in Yemen there are women die of something that should be normal, which is pregnancy and giving birth, each 2.5 days. So each 2.5 days, there is a woman who passes away because she's not taking the appropriate care during pregnancy or during birth. So this simple information can make us understand many things. And this big number does not include all women who pass away because of maternity reasons, and because no one document these deaths appropriately. We have reports that there are 5,000 health facilities. Only half of them work with full capacity. Especially in the countryside areas, we have a big lack of doctors and big lack of health facilities. Yemen also had a lot of cases of cholera, COVID-19, and even in the diseases that the world started to eliminate, we still have cases of measles. And these kind of diseases did disappear in many parts of the world, but Yemen is still suffering from, and we can prevent them through immunization or something like that. So, as you see, there is many people who are very much qualified of the Yemeni doctors, but they work abroad, and we cannot benefit Yemen because we cannot reach Yemen and we cannot meet all together. That's why I'm very thankful for this conference who made us meet a lot of important people. So I hope that we will keep communicating with each other and to have a continuous communication in order to benefit from expertise out of Yemen. And we do not ignore, of course, the efficient, high qualified people who live in Yemen, but we need to create this connection between us. I will not talk a lot about the problems, but I will only shed the light on the most important problems that the health sector in Yemen faces, which is the health information. The health information are either limited or not updated. So a person cannot define the priorities depending on statistics, because we cannot define the rates of the problems. So I don't want to keep reminding you that the doctors, they are not receiving their salaries, or they are volunteering, or they have problems in relation to the updates for their information, or problems of receiving continuous training and developing their skills. So all of that will increase the ability of the health sector to provide a better service. On the other hand, there are a lot of donors. About how the donors work, it is not by a must will lead to something tangible on the ground. The last donor conference said that donors the people are tired and they don't know how to help the country. So as the health staff, we need to draw the roadmap for the donors, for them to know how can they support us in a way that will lead to the development of our country. I have some suggestions depending on the research I made. So the extensive search I made, I found out that there are many interventions that were not of benefit. They led to nothing. But other interventions can be of benefit to the health sector. In terms of actions, we need to ensure that the citizens reach to any kind of the preventive measures. And here we should be focusing on two things. First, the mobile clinic. As long as the health facilities are working only off of 50% of their capacity, so we need mobile clinics because they will reach out to more citizens and they can provide several health services, but not all health services can be provided through mobile clinics. That's why we need to focus on a community-based health intervention, which is the health services that are close to the citizens. So I can train midwives or nurses. So we should not focus only on doctors. We can focus more on things that will prevent death, like vaccines, like nutrition services, so to prevent death. We call it prevent interventions, and many successful interventions succeeded like that. One of them is the UNICEF program, and it was implemented in 2 provinces, and it focused on IDPs. But it was a mistake to focus only on IDPs, because to focus on the IDPs while the hosting community itself is suffering is a problem. So we should not only focus on one group while we are providing the health services. Community-based clinics, it was proved when I reviewed literature that it will enhance the health of the community, especially if we focus on the preventative health interventions. Also, we need to work on the rehabilitation of the health facilities. We cannot provide a service of care during pregnancy, but then we don't provide healthcare for the women when delivering the baby. We need a comprehensive health services to be provided. We need also soap, we need health, pure water. At least we need to scale up the services so we can keep the lives of the women. So we need also midwife, etc. So this intervention was implemented by WHO in 13 provinces, and many health facilities benefited from it. But unfortunately, unfortunately, it was a temporary project, and it ended with the end of the fund. So we need sustainable support for similar projects, and it should be owned by the local authority. So when you cannot provide a service for a certain period of time and then leave, we need to make that project owned by the local authorities, and for them to want that project and to feel that they own it really, so that will be of a real help to the citizens. The third intervention, which is very important, which is to take care of the medical staff. The doctors who are in Yemen, for me, are superheroes. They work without salaries. They should have incentive. They should also be protected even from diseases, from contagious diseases. And they should be receiving more training, and also as a health service cannot be provided if the doctor does not feel safe. So safety is very important for the doctors. We should understand that health is is something very far from politics, and health services should be provided in parallel and away from the political conflict that is happening. On the midterm, there is a very important thing that the studies showed us that Yemen does not have, and we should focus on, which is the inclusive coordination. We have an initiative, for example. We have an initiative, and I was surprised by a big number of initiatives in Yemen. Those are the documented initiative, and we have the non-documented initiative. When everyone works alone, you find the interventions on the level of the governorates, and we don't have any coordination. So who should create this health cluster? I don't know what cluster mean in Arabic, but these are the clusters, and they have their own policies, and initiatives can be part of them, and they can amend the policies of the clusters if they are part of it. But we need to sit all together and to be away from the policy that I don't like to work with the North, or I don't want to work with the South. All of these things are keeping us backwarded, and we need to coordinate together. The other point is that to show the road to the donors. What do I mean by showing the road to the donors? I used to work with USAID, and I worked with UNFPA and UNICEF and the World Bank. And from my experience with all of these organizations, I wanted to shout at the Yemeni people, oh, people of Yemen, do not be only a messenger. Don't only take the message from the donor and transfer it or transfer the money to the country. We should have a vision of our own. So I take the money from the donor, and I plan, and I see where is the good place to put that money in. I will share with you a very simple experience. is because some people might say we cannot enlike the donors. The donors have their own plan and they want us to stick to their plan. But actually, from my experience, one of the donors, and he was considered the main donor in Yemen in relation to health services in general. They used to give them money to the Ministry of Health in a way that I saw that was not a good way, not sufficient way. So I suggested for them to use something, the performance-based violence, and it is a way to direct funding depending on the performance. For example, I enter a hospital, so we ask the hospital to raise their capacity in regard to delivering children, for example, or delivering babies, and then I asked the hospital to tell me the budget for them to enhance that service, and then I would ask the hospital to spend part of that money first, and then if they worked well, I will give them the rest of the money. So to have the funding that is based on performance enhanced the health care provided in that area up to a 60%. So it is a performance-based financing. So I hope that similar research and the people who work on research, if we can direct these researches to development and lead the donors and show them the road on how they can help us in a way that is aligned with the needs, real needs of Yemen, especially in the health sector. I actually wanted to publish this scientific academic paper, but we don't have the needed funding for such a publication. But hopefully we will cooperate together and we will focus on the research that will be helping our own country. So for me, this is one of the very important things that I'd like to be as one of the recommendations of our conference. First, to sit all of us together on one table and to think together, and we should be inclusive and not exclusive. The researchers abroad, we are ready to help you with all what we have. And we need to communicate with the experts in Yemen, and we should not only focus on the humanitarian development, but we should have a focus on the developmental part too. And we should have also a partnership, whether between us in Yemen and outside Yemen, and with the Arab area and other countries. Thank you for listening to me. Actually, I wanted to be with you here in this great meeting, but it was not meant to be this time. So I hope I can meet you in another time. And thank you so much. And sorry if I took a lot from your time.
Thank you so much, Dr. Mariam. Of course, we know that what has been said is very important and it's a lot of dialogue. But as you know, the questions and answers will be postponed till the end of the session. We will move directly to the next presentation, Medical Education in Yemen, Opportunities and Risk, Dr. Abdul Yazid. Dr. Abdul Yazid is a professor of chest diseases, Faculty of Medicine, Hadramaut University, associate chest disease Faculty of Medicine, Hadramaut University in Yemen, and Deputy President for the Head of Medicine School and Hadramaut University, Yemen. because I have only 15 minutes, it's not enough, but I wanted to take this opportunity to thank the foundation who invited us to this conference, and to everybody who worked hard to make this a successful conference. We actually witness here a model of how the Yemeni person might be created. Thank you so much for everybody who has worked for the success of this conference. Of course, I'm talking about medical education, risks, opportunities, and a way to go out safely from all these problematic issues inside it. We need to have a look at the medical education here. Beginnings happened in 1965 in Sana'a and Aden, when first National Health Conference was held also in 1972, and at the time some of the graduates who were sent abroad before the first National Health Conference in Aden and Sana'a was established. It worked for 5 years. Then the graduates increased in 1919 July. The first conference was held. Inside that conference, dreams were discussed. The first dream was to establish the first medicine school. In 1997, they started putting the things together. In September till the end of December, the first team and cadre of the professors were selected. Through the first half of 1975, this team sent to Cuba to learn knowledge about medicine schools management, and in September 1975 they went back, and there were 65 doctors, female and male doctors. And the numbers increased in a very fast way, to the extent that I cannot now count the number of the medicine schools there in Yemen. Our methodology in this study, of course, everybody here suffers from the database, lack of information, lack of data. So it was for us an objective to examine the reality of medical education in Yemen, the factors affecting it through a realistic description of the risks, and we tried to collect data in cooperation with our colleagues in Liverpool, and also you cannot find it in PubMed or in media. We just we're able to find this information through our communications, personal communications, and we try to find some references. And in the beginning, this effort was the effort of the writer who worked more than 30 years in research and in medical sphere. And then, so it shouldn't be only talking theoretically about opportunities and challenges and finding solutions. We are talking about an actual on-ground experience, and we played part in this experience. It was a case study of the College of Medicine and Health Sciences at Hadramaut University, and how the challenges were faced and addressed. And although there are a lot of challenges that are still there, what are the challenges now? We can just talk about them briefly here. First of all, the state of instability in the country for a long time or prolonged time, the absence of the state also, and absence of laws, resulting in corruption, and the absence of management. Corruption increased a lot, and it touched all the sectors, including the education and healthcare, also poor basic services such as electricity and internet, poor infrastructure. There are no school of medicine that has its own hospital. They all depend on hospitals of the health ministry or Ministry of Health, and they are poor in their equipments. In Hadramaut, we might say that we have half hospital. About the academic staff, of course, after the crisis, because of immigration, we have lack of academic staff and low salaries and low retirement wages. There is no central body with the authority to regulate the admission of students and graduates, American students. Then absence of the practical monitoring on the medical profession standards on medical maybe there should be a medical council. I think we have a council, but its role is limited on the fees, certificates, and such things, and it doesn't have any other role. There is no independent assessment to verify the ability for graduates to practice the profession. There is no clear standards. Levels of teaching in medical schools usually are not the same. The medicine schools sometimes lie under pressure to employ some professors, and we have a variety of diversity of professors belonging to different schools. Sometimes this is positive, but sometimes it is chaotic and negative. Funding for medical education is not clearly defined, and it is not one of the priorities of our state. This is the last thing they think about. The opportunities. What are the opportunities? What are the lights that might be used wisely? For example, using modern technology in medical education, such as simulation, artificial telemedicine, intelligence training, and also the communications, remote training. There is also an opportunity to create partnerships, not only WHO, UNICEF, and other things. Maybe local partnerships will become very successful and bridge some of the gaps we have between Yemeni universities, between medicine schools, offices of health ministry, and its hospitals, depending on win-win policy. There should, everybody should win. These hospitals also should win in this thing. Private hospitals, maybe some will get shocked when I talk about the role of private hospitals in education. This is an experience we went through in Hadramaut University, and it opened for us horizons, and I'd like to grab your attention to it, because the owners of these hospitals and the teams working there, they are sometimes professors in the medicine schools. Now, what is the experience of medicine school in Hadramaut? Let me just give you a glimpse about it. It was founded in 1997, and having one part which is medicine, then then pharmacy was added, pharmacy system. was added, and this is the only specialization that exists there, which is rare in the Arab area. Then 2013, medical laboratories added there, and this was an answer to the needs there. Uh, Graduates until 2024, 2,352 male and female doctors, 415 male and female pharmacists in pharmacy system, and 572 bachelor's degree holders in medical laboratories. And then there were all postgraduate studies founded there, and there was a cooperation between Hadramaut and Fadida University in giving master degrees about general health, and during 2 years 26 students were able to have their masters. This school, when it was established in 1979, this was the result of a very particular plan, and the curriculum was the periodic review of the scientific curricula, vision, mission, and objectives report. And the system was problem-based learning, PBL, which is a very nice program, but it's not, the time is not enough to talk about it. There was a decision making back then to review the scientific curriculum and also to define the vision, mission, and objectives. And this was reviewed in 2003-2004 after graduation of the first group from that school. In 2004, this medicine school was in the first WFME, in which the 9 standards were put. And after taking part of this conference, a program for quality and academic accreditation was founded, also in the medicine school in Hadramaut University, and also a center for academic improvement also was founded, not only in the clinic related studies, but also about program evaluation, student evaluation, performance evaluation in the school. And the 9 standards were adopted. 9 standards of the World Federation for Medical Education were adopted. How can we say that we are going to abide by them? But actually it wasn't easy, but we were able to solve a big part of it. The committees were created back then, working committees, curriculum committee, of course. And one of the innovations of the medicine school back then, in order to solve the problem of the lack of funding, the medicine school gave a paper and project plan for a fund, and they got $1.8 billion to improve the school. And with this program, we were able to open the way to good improvements, and we sent almost all the cadres in working there to get better studies on curriculum, for example, on preference evaluation committee, and there were exchange of expertise between Munich and Hadramaut, and I can say that more than 90% of people working in Hadramaut University got very high level of education due to this grant. And we were able to create the first skill laboratory and also audiovisual laboratory also, and we were able to introduce fiber net to the college or to this medicine school. And this grant was renewed for additional 4 years, and this is something that had never happened before, and it ended in 2012. During this time in 2010, in the medicine school, we asked to do a scientific and knowledge revolution. Together, the logo was together towards academic accreditation. This trend took place back, and committees were created in order to meet the 9 standards. In each committee there were some professors and some students, and the problem-based learning is based upon the idea that education should be human-based and community targeted and integrated. Then these are the main aspects of problem-based. Also, establishment of a university hospital for gynecology, obstetrics and pediatrics. It's a small hospital. This happened in partnership with the Ministry of Health and the private sector, using the hospitals of health ministry, meaning that the university will prepare places for education and training, and also the staff would go there in the hospital to provide services and teach their students at the same time. What are the criteria for student admission? Everybody knows that we actually talked about this thing in Hadramaut, because we used to work there as the head of the union of the professors, and also as a lecturer there. We were able to get or gain a decision to change the admission criteria and to do an exam, 60% for the results of the exam. This since 2014. And it's done through optic mark recognition, and so human factor is not interfering in the results of this exam. And one of the staff there in our Hadramaut modified this system, and the also acceptance exams were integrated with the high school exams there, and also optic mark recognition. I told about it. Also, the passage of electronic library via an offline internet that included hundreds of modern medical references. What are our recommendations? I recommend that each one of these recommendations will have a workshop and have a committee to implement it, activate partnerships in training, update curriculum, and encouraging scientific research, activating the use of technology to fill gaps, material, as it is done in our university from the 3rd level. They write researchers. When they graduate, they are well versed in the research and scientific research, activating the use of technology to fill gaps, material moral incentives. We invented the rare specialties, and this is very specific to our university. The conclusion: a few days ago, Nobel Prizes were discussed, and they were given to different specialties there, and the knowledge and science part. Also, some doctors gain. One of them was Dr. Omar Yaghi. When the announcement after the announcement of his gaining this reward, a lot of countries ran to say he is Saudi, no American, no Palestinian. I want to derive something from here. Give the researcher a secure environment in which he can stand firmly on basics of infrastructure that open the way um, to to build the research. Yes, we can. We also can use it. Yes, we can, because we are the people with heritage, and we are the people who taught humanity about culture, and we are able to recreate it. There is a final slide. Where is it? Thank you. For sure, we will find our way to safe way out. Thank you so much. Thank you, Dr. Abdul Qadir. And we will end this with this picture from Mukalla.
So the third and second presentation focused a lot on the Yemeni medical staff, whether on networking between the staff in Yemen or outside of Yemen, or to qualify those who are in Yemen. And now we move to another place, which is to rebuild the Yemeni health sector. Dr. Khalid Sulaybi will be talking about rebuilding the health system in Yemen through the strategies of the general medicine with the connecting it with other types of medicine. And he has PhD from general medicine with from Liverpool University, and he acquired MA in general medicine, and now he works in Doha, Qatar. Thank you, Dr. Burhan, and many thanks to the scientific committee and those who organized this conference. We are here with our colleagues to talk together and discuss some idea. Actually, Dr. Marwan, when he talked to me about the way out, I told him how we are gonna find our way out under this situation. But after listening to my colleagues in the first session and the successful experiences and what was talking about, I think that we can talk about rebuilding the health system. Actually, we want to merge between the integrating medicine with public health. And I'm very happy that we are talking about medicine and public health, and we have this idea in our minds as a community and as a medicine staff. The outline of my presentation is in English, so sorry for that, but I will be explaining it in Arabic as much as I can. As a background, I will be talking about what is the background that let us reach to this point. The problem of the health system is not only a thing that happened after the war, but the problem started since before the war. However, the war made the problem more complex. So we need to look at these things with an evidence-based thinking. And also I suggested 3 ways out or horizons for the way out in relation to the health system. Since 10 years ago, I called it stabilization, then transforming. And I will be with you on how we can make this integration between clinical medicine and public health will help us in solving many problems. And many of the health services provided in the countryside depend on the first aid health services. or primary care health services, so that the health service will be going to the person rather than him coming to the health facility. And also I'll be talking about calling to action, about the measures we can take in order to solve the problem. And we will talk about the risk and mitigation. As for the background, very quickly, Dr. Mariam talked about the background. Actually, this is our reality now. We have a collapsed health system because of old and recent problems. 46% of the health facilities are not working, and we have a chronic, recurrent system, and we have problems that recurring outbreaks, and we have diseases that happen again and again, although it was eliminated around the world, like cholera, like measles, like polio. We have also the mass displacement, and I'd like to focus on the WASH issue. It is an abbreviation for water, sanitation, and hygiene. All of these elements affect the health system, and they are very important because it is very difficult to it's very difficult for us to reach pure water, clean water, and you have problem with hygiene and with the sanitation. The health facilities currently are not working, are out of service. So what is the as Dr. mentioned, only the health facilities are working only with a capacity of 50%. And as everyone knows, most of the hospitals that we depend on for treatment are in the main cities, while the biggest need is in the countryside. In the countryside, we have only health units or simple clinics. So we have health problems in the countryside with no health services being provided. The current health system now is working, but it depends on the humanitarian backbone, which means the humanitarian support. So the country, as the youth mentioned, that we are not able to provide main health services. Personally, I don't see it as a lack of resources. Rather, we need to rethink of these things as researchers, as thinkers, to see how can the best thing we can provide with these limited resources. So what about the current burden and risks? First one is cholera, second measles, we have also polio and malnutrition. So the Yemeni community suffers from these diseases. So how can we help the Yemeni community, especially in regard to the malnutrition? It is not a health problem, it's rather it's not a health disease, but it is a health problem, but it is related with the food, with the ability of buying the basic materials. So here I have a malnutrition. When I have a malnutrition, I go to the health facility, but why do I have to get malnutrition in the first place if I had a good economic condition? And then let us now move to what I call the resilience sample. So we need to think of the health system. Health is not only to get out or to leave or to be clear of diseases. Rather, it is to maintain this balance between your physical, mental, and psychological aspects. So we need to focus on all of these things together. In Yemen, we need to combine between the clinical medicine and public health. Types of way out. We have three horizons. The first one, I called it stability, and we need from 1 to 1.5 years for stability, then rebuild, and then the transformation. In the stage of stability, we need to keep the light on. So we need to have our hope. We need to stop epidemics, to protect mothers and children's. Because women and children in countryside are usually deprived from health services. The second phase is to rebuild health system in Yemen. It was in its best cases in Yemen when we used to have a primary care networks. But now we have health services focused in the cities, and the HRH and the primary care networks are now very weak, and the villages and towns currently have no health centers. And we should take into consideration that we are a community that has a lot of countryside area, so we need to refocus again on the countryside. The third phase is a transformation phase. It would take us 10 years or up to 10 years. And the timeline indicated here does not mean that they will happen one after another. They can happen all together, but we need to look for stability. Then we start with rebuilding some of successful examples for primary care centers, and then how can we use digital or telehealth, climate resilient, also to have a climate resilient wash. So here we need to focus a lot on the way out, on how we can control epidemics. In Yemen, we are going from one epidemic to another. The problem with the epidemics that they are not because of the lack of the health system in the country. Rather, it is a lack of the developmental part in our country. So if we don't have clean water, if we don't have sufficient food, then we will have health problems, because most of the health problem is related to the impure water and the lack of food. As people outside of the country, we can help them through the sustainable skill CME, which is a training, some type of training that we can do for them. So we have to help them and to support them, so at least we can make such trainings and conduct scientific forums. In the second phase, the rebuild phase, in that phase, we need not more specialists, we need more doctors of general or public health, because we need them to work in the countryside and to be in all hospitals. I don't say that we don't need specialists. We need specialists, but what is the urgent need now? The urgent need is in clinical medicine and public health. In the last phase, which is the funding, the governance also, the digital and telehealth, and how to build a climate and resilient, how we can work, build a system that is resilient. And now, what about the cross-cutting enablers? So when a partnership is important, so we need to design the partnership through the governmental, non-governmental actors, and we need to promote accountability. Also, accountability is not only on state employees, it should also be on humanitarian workers, on everyone. We need also to regain the trust of the community. So we have now zero trust. I have a study that was conducted on the 90s on Yemeni patients in Jordan, and they said that we do not trust the health service in Yemen, and that was 20 years ago. So now, how can we integrate clinical medicine with public health? We can do that because they complete each other. For example, the clinical intervention is to keep the life, whilst the the clinical medicine clinical intervention, we save lives, while in public health we prevent and reduce risk. In clinical intervention we have standardized protocols, while in public health we have population data and early warning. In clinical interventions we have continuity of care, while in public health we have behavior and trust. For example, cholera can be dealt with through arrays, but it's not enough. I need to provide healthy water, sanitation. Otherwise, people will get sick again. But if I continued this work with the public health intervention, it will be better. Also, most donors focus on emergency care. But if we have community attendants, birth attendants who work with the mother since pregnancy till birth, because the pregnancy is a physiological function which is a normal thing. So the community birth attendant, if they are trained in well, they can help. So here is the complementarity, and so we need to make the health system a complementary system that combines the protocols of clinical packages with public health packages. As for the we have the non-contagious diseases like the LCDs, like hypertension. So in these diseases, we focus on the clinical packages more than the prevention factors. However, we should be looking on it from a way that would also prevent the disease. As for the traumas and emergency, for example, if I have a car accident, we treat it as an emergency, but actually the main reason for the car accidents are the unsafe roads, so the roads are not safe. In Yemen, we drive cars with no periodic check on the cars. Sometimes you see cars that are not in a way that would allow it to go in the street, but when the accident happened, they say that's what Allah destinated for us, but they did not take good care of the roads or of the cars. So that's why we call it that we need to have health policies included with all different kinds of policies, like education, like agriculture, like roads, etc. You have only 2 minutes. So the complementary package is on how we can rethink of health system and integrate the clinical medicine with public health, and we also need to have district integration operating model, also in regard to the 10 actions suggested. If we can take 10 steps after this conference to make this integration, how can we keep our medicine staff through CME trainings? Also, how can we provide them with basic things like oxygen reliability? And how can we use solar for cold chains? And also the cholera, the measles, the subvisibility. Last but not least, also the community engagement. I believe that health system cannot be enhanced unless the community participated in health care, and they should have a role in decision making. Finally, we should try to protect life-saving services today while building resilient systems for tomorrow. This is my message for you. The clinical system, we can provide a health service with a minimum level, but if we want a health system in Yemen, we need to make this integration between the two systems. I have written a chapter in a book for those who want to read it. The book was about more than 40 countries, and I wrote a chapter on Yemen, and it had this title of integrating these different systems of health, integrating public health and primary care, a strategy for health system of the future. And thank you so much.
Thank you so much, Dr. Khaled. Thank you so much, Dr. Khalid, for your presentation. Of course, this is a very valuable and interesting presentation. We might reach stability within health stability within 18 months. This is hopeful, but let's go from the 18th month to see if the artificial intelligence can give a fast service to the Yemeni patient. We have Dr. Hamdi Al-Hakim, who's going to talk to us about artificial intelligence, innovative strategies for Yemeni patients to access local care and cross-border treatment. Dr. Hamdi holds PhD in social medicine, and he's a community medicine specialist, expert in medical statistics and artificial intelligence applications for diagnosis. The floor is yours, Dr. Hamdi. Assalamu alaikum. Peace be upon you. First, thanks for organizers of this conference that gathers people from all around the world, and I think if we have larger and larger conferences, we will get to know more and more people. Today I heard successful stories. We can gather them. We are researchers who is enthusiastic about AI. Not all of you, but it's a good number of you. Who is not enthusiastic, who have fears from AI? Who is in the middle, like he doesn't care about AI? AI, actually, they at the beginning said AI will replace all the jobs, but I used to say it's going to reshape vacancies and jobs in the medical sphere. Let me give you just a glimpse about myself, and I taught a lot about data analysis and I used to be an academic person. After that, I moved to Holland and studied the statistics and clinical epidemiology and data analysis. This was a turning point for me, but the other bigger turning point is that I was selected in a team to talk about using AI in cardiology. And it was 2017, 2018. AI was back then not very popular. We were like 100 of groups, and only two groups were working on AI. ChatGPT and the hype and trends came, and we found ourselves in the beginning and being asked how can we integrate AI into medicine. It's a very difficult question, and we are still brainstorming. And I am a person who follow up all the updates about AI, especially in medicine. The world is still scrolling, just stepping its first steps. Even the uh, biggest epic just included AI in a very particular specific field. In our University of Rochting, now we have an institution uh, to modify the uh, theses of PhD and master to be beneficial to in the marketplace, and then we will they include success cost around 15% to fund the other projects that will come later. And then they can also raise fund from supporters to Yemen, because about the greater reality, how it works in the medicine, in genetics, in diagnostics. But this took me a lot of time, and that is why I decided as a researcher to go through a methodology. Let's go to this slide. The general idea is how to have innovative strategies or innovative solutions for Yemeni patients. They should be simple, applicable for our reality in Yemen. I always try to focus on quality, saving doctor time, reducing medical expenses that burden patients. I will mention some titles because each solution will need time and maybe a number of lectures to be explained. Okay. Now, what's the research objective? It is to identify ready-made and workable artificial intelligence tools, taking into account the internet network condition in Yemen in order to facilitate the treatment of patients. When I talk about AI, that it helps and fosters the health insurance and other things, this doesn't exist in Yemen. But we have how patients can find treatment or medical care and medical services easily, and how can the doctor or the hospital treat these patients as 50% of health facilities working. In addition to long travel distances, people coming from different areas, patients have to travel for miles in order to find services. Also expenditures, the need for low-cost or highly effective options, and the population is growing, and the demand for medical service at home and abroad also is imminent. And what about the research points? And these are the techniques found in PubMed, SCOAS, and other places about what are the successful ways, even if they were very simple. And I tried with 10, then I end up choosing 3 of them, which is better for our situation, which are better for our situation for today. AI documentation, co-pilots, phones, hosts, and do systematic search in the databases, and then filtration. What are the results of this search? The first scope I found through documentation, especially in Yemen, because this sphere is weak in Yemen, and I worked with her in data analysis, and I know the importance of documentation. So AI assists fill out forms and automatically populate physician notes in the patient's electronic records. Now we have speech-to-text technology. This is easy. Now it's more accurate, easier to use, better understands better the terms, medical terms, and it's still, of course, improving. And I attended a conference in Saudi Arabia in مستشفى Al Habib Hospital, and they had a microphone next to the doctor that will record the the dialogue between doctor and the patient, even if it was in the army dialect and not in Fusha, and kind of translated into a formal language and medical terms, and doctor only goes to look at it. So this is integration of AI models within the patient's record to help write treatment plans, medical notes, and reports, saving physicians time. And this is Charlotte model that's connected to some hospitals, and in cooperation with a hospital in Yemen, we asked them also to use AI and use medical chatbots to put the plans, treatment plans, and this is the future, to integrate AI with patients' records and files. This is something simple. If they would say no, the patient will write for themselves, no. These research see that 50% of the time of the doctors and medicine health professionals is consumed in writing this information, so we can enhance the productivity of the medical staff by this way. Number 2 is I witnessed this thing in Yemen, and maybe it's appropriate. We can see how to refer patients to the appropriate specialty. There will be a platform, secure platform, and according to these files, the AI will refer it to the needed doctor. So it will reduce the number of visits that people go to general doctors and then be referred to other doctors which are not specialists and then to other doctors. We don't have the referral system here, primary healthcare, then secondary healthcare. So if we find a solution like that, it can help the patient according to his or her results, to direct them directly to the specialists that they need. How it works is about uploading reports and it will derive the best and the most needed and the most important medical information and categorize them and refer the minimum or the simple cases and refer the complicated one to a doctor. And number 3, cost calculation. We have a problem that we don't have health insurance in Yemen. I don't know if there is other country around the world doesn't have health insurance. Yes, there are. Okay, we're not alone. Okay, we don't have health insurance. The patient has to pay out of the pocket and he has to go through catastrophic health expenditure. Why is it catastrophic? Because they have to sell their house, sometimes their car, and in order just to cover the treatment expenditures. So is it possible to have a calculator, AI calculator, to calculate the cost for this patient if he moves from Taz to Aden in different also hospitals, or if he travels abroad to Egypt or India, then he studies his or she studies their budget and decide. Then they can take an informed decision. Then you can add something about the results of this treatment. Okay, there should be also database that is updated about the procedures, the prices, and then you can have standards for these services, like the service in X hospital is almost the same service in Y hospital. I remember in the old days we discussed the problem of medical corruption, and we read a study in Argentina. One of the mechanisms to stand in the face of corruption, they just openly discussed the costs of the medical equipment publicly, and this reduced corruption a lot. Because if a hospital buys a machine by 1 million, it doesn't make sense. The neighbor hospital bought it for 10 millions. Then when we have lists of prices, that will be more transparency, and the hospitals will agree on average for the services, for the costs of the services. What is the Yemen stack recommended? AI documentation co-pilot, referral matching, also of care. And my final messages: AI is not impossible in Yemen to be implemented. It is rather a necessity. It can be operated now simply to enhance the quality of treatment and documentation, saving time, reducing the burden, management burden. We can do a co-pilot version of it, try it in treatments. And thank you so much for your attention. Thank you so much, and I wish everybody in this room will be very enthusiastic about AI. Thank you so much. Thank you, Dr. Hamdi. I want just to ask you very fast because you was on time. And what in Hadramaut or Sana'a or in Taz in the field of AI? This is a very critical question. Okay, let's move now to our final speaker here online, Dr. Mustafa Al-Absi. Dr. Mustafa, can you hear us? Thank you. Yes, I can. Professor Mustafa Al-Absi is going to speak to us about words, a sustainable national system to support psychological recovery. You heard about a lot of problems in psychological medicine, and now with Professor Mustafa, he will provide us with some solutions and a vision. Can you hear me? Yes. Dr. Mustafa Al-Absi is Chair Professor of Neuroscience and Behavioral Medicine and Director of the International Health Research Institute, University of Minnesota, USA. He wrote a number of researches about pain management and behavioral medicine. And now he is the head of Europe and Africa and Middle East area. Thank you so much. It's my honor to be here among you, even if it's through online. And thanks for my colleagues for their invitation and preparation. Who is managing the PowerPoint, you or me? You can share the slides from your side. What can you see in this slide? Yes, we can see the second slide about what we're going to discuss. These four aspects we're going to talk about and discuss, but I want to be able within the time given to me to delve into some details. I will give you just some points and then we might in the future delve into more details, and I will try to be on time, and Dr. Marwan has the right to remind me when time is about to finish. I'm sure that you have heard from our colleagues about what's happening in Yemen after 10 years of war. Displacement, infrastructure collapsed, poverty spread, and this ends and results in a psychological crisis. More than 24 million person in general statistics, which are not very, might be not accurate, meaning that reality might be even worse than these numbers. 7 million people have problems, psychological problems, and these are also estimated number. And as you know, some other problems, behavioral problems, and other problems that spread in places of clashes. Uh, I'm sure that you have heard some of these numbers from Dr. Mariam, Dr. Khalid, these numbers about Yemen. I just want to mention that 45% of disorders, psychological disorders, are post-trauma disorders, PTSD. Also, the staff is limited in Yemen, especially those who work as psychotherapists. Of course, more than 50% of people, there are people who need support of these people who are in need for support can actually find services. And these numbers just give you an impression about what's going on. As you can see, in the high income countries, 60 specialists or psychologists for each 100,000 citizens. In Yemen, we have one or less than one for each 100,000. We have only 45 specialists in a population of 45 million people. These are some of the challenges, structural challenges, cultural challenges about social stigma. We still have the culture of keeping silent, staying silent, and this is an obstacle, and also the collapse of medical system. And these pictures will give us the reality of these numbers, daily life, obstruction and destruction, and lack of security and safety lived by our children, elderly men and women. So our message here is either to build a system for psychological health that goes hand in hand to rebuild this society, especially children who should live in a place where they have an infrastructure that will guide them to safety, security, and psychological welfare. Now I will mention something that will cause some disagreement between us, maybe. I know that there is disagreement about qat, and but in psychological content, I don't think that qat should be separated from any psychological crisis. In English, it is said it is the elephant in the room. It means that it is the unseen elephant in the room. This is what qat is. This is why we cannot have a successful strategy without dealing with this elephant that increases the health and politics, peace, all the problems in Yemen. So it is a must to deal with this elephant, which is qat. I'm not going to take a lot of time talking about it. I will just support my words by some research performed about qat in cooperation between our university and a number of Yemeni and African universities. But before we delve into the results, I think this is something new for you. The effect of it affects in the clinical situation that a lot of us refuse that cut might be addiction. That is why we cannot draw lines between a normal or casual consumer of cat and an addicted person who needs treatment. In general, cat in this slide, and I will give you shortly, it will give you just indications on how that the cat might increase our challenges we live in today and in the future. For example, people who consume cat, they suffer from higher higher probabilities for post-trauma and other psychological effects. It might also people who consume cat also tell us that the problem of cat that it affects the quality of sleep directly, and of course sleeping is very important, and having not having good sleep will be harmful to our body. It also increases the psychological problems, and consumers of cat some hormones are more than natural levels. Basically, in this slide it says the people who consume cat regularly, we can see that this habit forms biological pressure on them, also on reactions, less positive reaction, more negative reactions, resulting in being unable to deal with problems, to enjoy life. Also, the increase of increasing the potentials to become ill or sick from psychological effects. Also, the memory issue and attention and ability to deal with problems in an active way. And this is a slide, another slide about biological, and physiological changes that addiction to cat might result in. Also, some people don't agree with us that there's an addiction. 10 years ago I used to use it cautiously, but now maybe now I use it more in a more comfortable way because of the information I got from the studies conducted in Yemen and other places. And this is also a slide to tell us that cat might be a gate to use other things like tobacco, alcohol, drugs. Also, this is a study done in the United States of America and some African countries. Now, after this problem and problematic issue of cat, let's talk about our way to psychological well-being. First, It's a must that we agree that psychological well-being is not separated from peace. Neglecting psychological aspects after war is a barrier from that prevents nations from achieve peace. So these two issues should be reintegrated, and we are talking in particular about those who take part in any negotiations for peace or reconciliation. Fighting and parties usually become victims of shocks and traumas, and because of these shocks they lived, this will result in mistrust, and dealing with these issues, treating these psychological problems will help these parties and the society to reduce tension and build trust and write chapters of positive attitudes towards each other to facilitate negotiations towards real peace and social peace that is sustainable and durable. To go about our vision, about building this strategy, our vision is that we build a country in which citizens enjoy psychological well-being and resilience, and it is a must that we establish a comprehensive system that provide services, uh, mental services, psychological services, social support. This strategy, I'm thinking about it to be implemented within 5 years, and it includes five targets. First of all, merge some services, health services like primary health sector services, and establish 50 units for psychological services. And why I have these numbers? Because I have a vision about it, but I don't have time to give you the reasons behind these numbers. Number two, to train and employ from between 500 to 1,000 medical staff and those who are specialists in first aid, psychological services, and then to launch awareness campaigns in order to address the social stigma in relation to psychological treatment. I know that it's not easy, but everybody here can play a role to achieve this target. Also, we have another point to establish a fund, sustainable fund for this, and this is about the interference, how to divide the roles, and you don't put all the burden of work on the specialists, because it's the story begins from the baseline where the community as a whole takes place in this process through procedures to taken in order to listen the aftermath of shocks and traumas in playing a role in first aids and on how to deal with shocks and trauma. And the second level is non-specialized care, people who are clinical, who are nurses, general practitioners, the general medical doctors, who can play a role um, in helping and providing patients with some psychological services. And at the top comes the specialized care provided by specialists. This model is what is called task shifting, which means to give some of the task to some professionals who are not specialized in psychological sciences, but they have the chance to deal daily or on daily basis with patients. And this strategy is very important, and I call for it in all contexts, each countries I visit, which is the importance that the first aid service will include psychological care. And in this context, I advocate for 50 centers will be integrated and built inside medical centers within the coming 5 years. Of course, the supplies of medicine, especially the basic medicines needed for depression, for example, there should be mechanisms to provide this kind of medicine in order for the situation to get better in dealing with these psychological problems. Also, other details, maybe we will keep them for some time later. The other thing is to building abilities, and this is mentioned in our previous sessions, that our problem that we have limited abilities, and that limited abilities, people who are capable have abilities also escaped. A lot of them escaped, and that is why we suggest within the 5 coming years that from 500 to 1,000 workers in the healthcare system will be trained, and to adopt the system of training of trainers in order to have a sustainable work on that. Also, to improve the abilities and skills of doctors, doctors who are pediatrics, women doctors, and internal medicine and family medicine, to improve their abilities to diagnose the psychological disorders and psychological problems on a psychological level, centers for social support, some special centers that target, for example, women, displaced people, survival of violence, also some leaders like religious leaders might be partners in this aspect, but I always say that it's preferred that people who would work here should be able to go of people of awareness, social awareness, and readiness for partnerships with others, and uh, this will help us to reduce the negative effects of stigma. As for what is related to support, of course, government, I don't know what government we have these days, but a number of ministries might play a role. Some universities, we have some models of cooperation, models like our cooperation with Minnesota University. They might be successful models. Also, international organizations, also local organizations, funders might also play a part in this work and its sustainability, and they might play a role especially in building the capacities, needed capacities. Anyway, I'd like to say in all of these suggestions and strategies, we stand here ready to play a part in it, to give advice on it. We have a plan that include the details on how to implement this plan and how to evaluate it. and I worked with other colleagues on it, but I should mention here that fortunately in the Yemeni context some of these visions come as a continuity to some other strategies, because they were a strategy built for psychological health, but it wasn't implemented. And also in the new Yemen that will come for sure one day, we ask that everybody cooperate to ensure that we avoid all the barriers, and I'm sure that participants in this conference might play a role, active role in this. And the conclusion, there is no peace without inner peace. And the problem with Fuqat is a very essential problem that we need to stop its bad influence on the coming generations. That's why I would like to say that it's impossible to postpone investment in psychological well-being. And as I told you, any reconciliation endeavor should be done in the context of treating and also well-being of all the players in the field of this reconciliation. That's why I wish that my message have reached you first, and then behind you to all those you work with in Yemen. But as your role, you are of the you are influential in your society, and you play a very good role in this, and your institutions might play also be able to step forward in this strategy in order to become reality in the future, to reach sustainable health level for health care and all other health issues discussed by our colleagues. Thank you.